62-year-old female patient presented with weakness 6 weeks back. Subsequently, there was a hemorrhage that period. After 6 weeks, an angiogram was performed as patient was not hypertensive to look for any aneurysm or a AVM. To our suspicion went right, and we could see an AVM with a nidus approximately measuring 6 centimeters, which is receiving numerous feeders from the MCA and lenticulostriate branches. Subsequently, it was draining into the thalamostriate and internal cerebral veins. Hypertrophied vessels are also seen in the prepontine cistern. The gliosis secondary to previous hemorrhage resulting in exvacuodilatation of the ventricle also was very visible. This is a complicated AVM in the left capsuloganglionic region. As a radiologist, whenever you are seeing a capsuloganglionic AVM, we should report it diligently so that it helps the treating physician and neurointerventionist. So this case, patient had subacute presentation and there was a seizure. Ultimately, in non-contrast CT, we could see the SAH in supracellular, paracellular cistern and hemorrhage. In this case, we are able to appreciate encephalomalacia. An AVM with nidus was seen, which was around 23 into 30 mm. Feeding vessels, as I said, left MCA draining into thalamostriate and intercerebral vein. These were the features. My essence of the talk is Spetzler-Martin Grading. Always we should report in AVM Spetzler-Martin Grading. So the size of the nidus is less than 3 centimeters. So we have given 1 point in this patient. Subsequently, if you see if it is greater than 3 centimeters and less than 6 centimeters, you give 2 points for it. And greater than 6 centimeters, you give 3 points. Total score is like you can reach up to 5. Grade 1 is the low surgical risk, and grade 5 is high surgical risk. We should also consider whether it's an eloquent area, and we should consider the venous drainage in these cases. In our case, it was deep venous drainage and it was from eloquent cortex. Only favorable point in our case was there was a smaller nidus, less than 3 centimeters. Basically, this we have followed. There is also an alternative classification called Lawton-Young supplemented grading, which includes age, hemorrhagic presentation, nidus compactness. Treatment planning is ultimately traded to all these factors: age, SAH, deep basal ganglia involvement, all these things, nidus, whether it's compact or not, intra AVM aneurysms, which is again very, very important. For a small compact AVMs with accessible feeding arteries, they do endovascular embolization, which also helps in reducing the nidus value. In cases deep MCA perforators, there it is technically difficult because of high risk of infarct. So stereotactic radiosurgery is done for small nidus which is in deep eloquent areas. So this case is ideal suited for SRS. Gamma knife surgery can be performed. Ideal choice for this case. Age is again greater than 60 with a prior hemorrhage. This is how you have to grade and take the choice of the patient. Additional treatment options not favored because of deep location, deep venous drainage and eloquent motor, and also prior stroke. So ultimately, my teaching pearls for this case are always classify AVM using Spetzler-Martin Grading. It is a surgical risk, not a diagnostic severity. Look for associated aneurysms, feeding artery and intranidal because they have more hemorrhagic risk. So you can alarm the physician when to take a decision. Subsequently, AVMs in deep eloquent areas are often managed conservatively or with SRS, like in our case. Deep venous drainage has higher complication rate during surgery. This is one factor which is detrimental to the patient. Nidus compactness at clinical presentation will definitely change the management. In our case, an additional workup could have been done with a DSA and tractography to look what all fibers are involved. Final one-line summary is left basal ganglia, Spetzler-Martin grade 3/4 presenting as SAH and prior hemorrhage, infarct, encephalomalacia for DSA, stereotactic radiosurgery. Thank you very much. Hope this case was useful for you.